There are close to 800 medical colleges in the country now. About 40 of them would have some palliative care. The others don't. After these 30 odd years, today palliative care access is limited to less than 4% of human beings in the country.
5%.
So it's in the curriculum. What are they teaching? Did you know that more than 4% of our countrymen go below poverty line by catastrophic healthcare expenditure? We are one of the top 12 countries in that kind of thing. Change will be resisted and that we have to accept. What do we get out of it? What do I get out of it? Tremendous satisfaction.
So there must have been huge amount of obstacles in your way. How did you manage all that?
Like
Hi, I'm Ramji Walat from Azim Premji Foundation. In this show, we bring to you stories from the world of health. These are stories from the front line, stories of path-breaking work. This is the health worker. So what exactly is palliative care? A simplistic definition is pain management. But in reality, it's a lot more than that. To explain better, we have with us Dr. Rajagopal, who dedicated the last 4 decades of his life into spreading awareness as well as spreading the practice of palliative care across the country. He is also the founder and chairman emeritus of Pallium India, an organization working extensively in the space of palliative care. I had a long chat with him, and I would like to share the details of that inspiring chat with all of you. Welcome, Dr. Rajagopal.
hello, good morning.
So my first question to you, what is palliative care and why is it important?
Yes, these definitions can sometimes be very limiting. They handcuff you. It's good to have definitions so that we have clarity. Palliative care is mitigation of all serious health-related suffering and improving the quality of life of the person with the illness and of the family. That would be one current definition of palliative care.
Okay, so it's not just confined to the person, it's the family, and it's not just physical pain, it's also social, psychological,
And
all kinds of,
spiritual
and
pain.
spiritual pain. Okay, this is something which there's a lot of mysticism around it. Nobody really knows exactly what it is.
True.
So tell me, sir, what is it that made you get into something like palliative care when I don't think palliative care was really talked about 3 decades back?
When I was a medical student, such a long time back, I had a neighbor living about 100 meters away from me. All through night, I could hear him screaming. He had cancer, numerous nodules on his scalp, and he felt it was like somebody drilling into his skull. He had got chemotherapy even in those days, but no pain management. Night after night, I would hear the screams. They asked me, could I help as a medical student? Of course, I couldn't do anything, and I just walked away and avoided going back to him. I now realized that I was afraid. Then, as a medical student in the wards, as a young doctor, I saw so much of suffering. Suffering filled the hospital. But we were taught, I would say that, without somebody putting in so many words, to turn away from suffering because that would destroy us. Concentrate on the body, on the disease, on the organs. I somehow managed to do that. But eventually, when I had the courage and opportunity, I started treating people's pain. I treated the pain of a 42-year-old college professor. He had agonizing pain over here from cancer. I put in a needle into a particular nerve over here and killed the pain. I was very happy. I was patting myself on the shoulder. The man went home and killed himself that night.
My God.
Because till I did this, he thought he was having a curable cancer. And when I told him, you will be pain-free, this injection will make you pain-free for about 5 to 6 months. If you have pain, you come back to me. Then he knew That professor gave up his life to teach me a lesson that a human being is more than nerves and cancer and tumors and chemistry, that a person has emotions, feelings. I had refused to see the person. I was treating only a particular nerve. And I think that was life changing for me.
That's a very powerful story, sir. Then, subsequently, how did you take this forward, and what is your subsequent journey in terms of getting into this?
So I started listening to people and not just looking at nerves. And people taught me a lot. They would talk about themselves. Most of them were very eager for somebody to talk to. And then I came upon a book by Dr. Robert Wycross, who later became my teacher. And I listened to a lecture by a visiting nurse to Trivandrum. Her name was Jilly Byrne. And the book and Jilly Byrne's lectures opened up this world of palliative care to me.
This must have been a very difficult journey because you had to not only learn about it, you had to then convince the system that this is important. So there must have been huge amount of obstacles in your way. How did you manage all that?
There were obstacles. Most importantly, my own personal limitations. I was not a go-getter, I was not an extrovert at all. I was not somebody to grab opportunities, jump at them and fight my way through. So I was a major limitation. But also the resistance to change. Any change is resisted. By most. There are a few eccentrics like me who would welcome change. That's nice. Let us explore that. But the majority of people are not comfortable with this. And much of that discomfort comes out of fear. What's all this? We are okay now. Why do you want to disrupt everything? Kind of thought. And fear may bring on anger. Now, a small proportion of people will be violently angry and will fight. Everybody must have felt it whenever you thought something new. Some people would be fighters. And this is what happened in Kerala. In Kerala, there are more tens of thousands of active volunteers in the field of palliative care, spread out about over more than 350 palliative care centers in small neighborhoods. Today.
Wow.
So how did that come about? That was gradually these middle level people slowly coming to this. Change will be resisted, and that we have to accept.
Yes, absolutely. So work on the people who are more ready, make them early adopters, and then slowly the word of mouth will spread and the people who are neutral will start shifting in.
Exactly.
And you don't have to really spend your energy on the negative people.
Absolutely. Those mountains of obstacles are still there. After these 30 odd years, today palliative care access is limited to less than 4% of human beings in the country. There are still 7 to 10 million Indians in suffering. If only we could reach the most important people, the decision makers, both in central government and state governments, then many things would be easy. Most of the achievements, like the National Program for Palliative Care, like the inclusion of palliative care in national health policy now, like the inclusion of palliative care in MBBS and nursing curricula, all these were brought in by some key people, mostly bureaucrats.
Okay.
Mostly non-medical bureaucrats, I must say.
Excellent. That's great news.
But it's a question of finding them and they having enough time before that person gets shifted to the industries ministry.
Yeah.
So these disappointments happen. There is so much that could be done. And if only we could overcome the major resistance from the healthcare scene itself, and also from the governmental agencies.
Okay.
The people on the ground are the easiest to change.
Okay.
They are like an empty glass.
Right.
You can pour more into it.
Wonderful. So I do have a disagreement with you. I think you do have a lot of grit, and that actually overcomes a lot of timidity, etc., of the person.
The grit, yes, indeed. And there's also two lessons there that make up my weaknesses with colleagues who have more energy and more enthusiasm. One. But the secondly is to be persistent. Okay, I am like that. I have my limitations, but still I move forward.
Right.
And if there is I won't bang head against that brick wall, but I'll try to find a way around it.
So how does one integrate palliative care into the healthcare system according to you?
Ramji, when you say that healthcare professionals have understood it, I don't think they have. Okay. By and large, it's a lot of misconception. Many people think it's only pain management. Many doctors and nurses think it's only for cancer and only for end of life. So there's a lot of misconception about it. Some key decision makers have created those policies, but it has not percolated down below. So the implementation gap is huge.
Mm-hmm.
There are how many? Close to 800 medical colleges in the country now.
Right.
About 40 of them would have some palliative care. The others don't.
That's just 5%.
So it's in the curriculum. What are they teaching? Either nothing or a little from some textbook, which may be quite outdated, found in the recesses of the medical college library. So long way to travel yet. In medical and nursing education, unless you see something happening, it's very difficult to get that translated to action by a medical student, doctor or nurse. You have to see it being practiced. Then it becomes real. That's where, hopefully, I hope the day will come when the National Program for Palliative Care, working in that corner in Delhi, and the National Health Policy here would get integrated together so that every health professional, students certainly learns to treat pain or breathlessness. There's a lot to be learned about that. We study diseases, not the symptoms. They learn that, but I hope they also learn to sit down beside the person just for 1 minute. They wouldn't have a lot of time. Not just look down upon them and talk to them, and learn to hold a hand, look into the eyes and say, I see you are suffering. We will do your best. And that will make an amazing difference. That you are not among human robots. You are among human beings who care.
So what can the government do to actually make this implementation happen?
I hope there will be a public audit of the National Program for Palliative Care and an action plan, implementation framework for implementation of the National Program for Palliative Care with the National Health Policy, incorporating the amendment of the narcotics law which happened in 2014 and the professional education. Oh my God, that would be a dream come true. What that would mean is that in 10 years, in that mountain of suffering, a huge part of it would have been scoped out.
And so when you're talking about implementation policy, it's for implementation plan, you're talking about every institution and every person in the healthcare profession should have their action plan very clearly defined.
Yes, every from the policy level, when it gets translated to the ground, that means every healthcare professional understands the principles of palliative care and applies that into his or her profession. But even now, There are online MOOC, the
Yeah.
massive online open courses available, which people can do it their own time. Those things are very easily available,
Right.
and more people are taking it.
Excellent. The last 3 decades, how has palliative care changed in the country? And could you sort of also explain what is the role of Pallium India and any other organization that you worked with to make that change happen?
The change, yes. It's not, I mean, it wouldn't be correct to say how much, what percentage is by Pallium India or anything like that.
Sure.
There are a
Yeah.
lot of efforts across the country now, including by the democratically elected representative organization, Indian Association of Palliative Care. So what has changed is that from next to no access to pain relief or palliative care 30 years back, today at least 4% of the people would have access to pain relief, and a smaller percentage, maybe somewhere between 2 to 3%, would have access to reasonable quality palliative care in the country. That's the positive side.
That's
The more than 96% of people writhing in pain is another shameful thing after all this time. But several positive trends have happened. I think we are on the steep part of a growth curve in terms of the government's national program for palliative care, inclusion of palliative care in the national health policy, the Kerala state policy of Kerala state palliative care policy, by which, did you know, every homebound patient in Kerala, in the 960 odd panchayats of Kerala, gets a visit by a trained palliative care nurse at home at least once a month.
That's amazing.
This is phenomenal.
That's amazing. Yeah.
Phenomenal as a beginning.
Yeah.
There is a lot to be built on it. So, and particularly the inclusion of palliative care in medical and nursing curriculum. That's tremendous.
That's a huge milestone.
Huge. There is huge implementation gap,
Yes.
as you can expect, particularly in our country. That needs to be filled, but I am very optimistic.
Big question. Why would a young doctor who is venturing into this profession or a nurse, why would they look at palliative care as a stream which they want to get into? What do they get out of it?
When we say they're getting into palliative care as a stream, as a specialty, doing it full time can be one thing. But as I said, medical and nursing curriculum has it. You include principles of palliative care into anything that you do, including cardiothoracic surgery. But what do we get out of it? What do I get out of it? Tremendous satisfaction. I had to live with the feeling that I was running away from suffering. Now we are able to open our eyes and our heart to that suffering. And then I don't have to say meaningless mumbling things. Oh, everything will be all right. We'll start a new medicine for you and walk away quickly. I can sit there for a minute, lay a hand on the hand, look the person in the eye, acknowledge his suffering, say, I see you are in tremendous pain. We are going to do something about it. We are going to walk with you on your journey. And then the change that happens to the person is a great gift to us. The way they hold our hands and bless us. Oh my God, that's a tremendous thing for the soul. I remember one person who came begging himself to be killed, and because he couldn't tolerate the pain, and his spouse saying, please finish him off. I can't bear to see this.
Yes.
The person was cursing God. What God? There is no God. And the same person held our nurse's hand in his hand and told her daughter in Malayalam, daughter, I thought there was no God. There is a God. He sent you to me as his angel.
Wow.
And wouldn't that give meaning to that nurse's life or to the doctor's life?
Absolutely.
And that is the pleasure that we get out of it. We don't have to turn away from suffering and escape. We can face it and get added meaning to their lives and enjoy the profession.
So, Dr. Rajagopal, you mentioned that it is not just physical suffering that we are alleviating. And there are some more things you mentioned. Can you just explain that a little more?
Okay. We learn to be human beings and not just medical machines. When that person in agony asks me to kill him and curses God, I don't have to preach to him. I just hold his hand and say, we will do the best for you. I see you are suffering. But then once the physical pain is treated, which might have been filling up the mind space, the other things emerge. This includes all his sadness of what might have been. Now, I was hopeful of doing all that. Now I cannot do any of that. The sadness, which may sometimes go into clinical depression, a depressive illness, which may have to be medically treated, or anxiety or guilt. How do you treat guilt? You just listen to the person. But then those are the emotional components. The social components can be huge, and particularly in our country, there can be much of it that is financial. Did you know that more than 4% of our countrymen go below poverty line by catastrophic healthcare expenditure? We are one of the top 12 countries in that kind of thing. Maybe you will not be able to solve all the financial problems, but you can listen to them, understand that, and also try to minimize the cost of treatment as much as possible.
Right.
And maybe find some social support. One social media post and support does come in. But the social problems are very often about relationships also. Somebody who has cared for a bedbound person for 10 years may now be burnt out. They have no more compassion to bring out. They do things mechanically. The disconnect will be obvious to the person suffering there. Nobody cares for me. The solution may be to sit together and talk about things, but it also means that we can provide some things that nobody else may do. It is not a very scientific thing. It's not easily measurable. That's called love.
Very
The
important.
love that any human being should have for every other human being. And then that also becomes part of the spiritual treatment. The spirituality is not only about God and religion and candles and incense. It's also about being valued as a person, having some meaning of life, some purpose of life. Without any purpose, why should people live? And we hear it frequently. Well, I wish I could go now. That could mean the ultimate acceptance, but more often it means I have no more meaning in life.
Yeah.
I have no purpose. And part of the management is making the person feel loved, even if there is nobody else to express that love. But it's also about finding purpose. Like a woman in her 40s dying of cancer was totally despondent because she couldn't be able to see her first grandchild who was due only in November. But then our team worked with her and started creating audio messages
Oh, wonderful.
for the child to hear at every birthday as the child grows.
Wow, what a wonderful thing to
And
do.
the woman was transformed. She had something meaningful to do. That's also spiritual support, but also keeping the person connected to what's important to that person. When I emotionally blackmailed my 93-year-old father to leave the village and took him away to live with me because I thought that would be safer, I had disconnected him completely from this world. And in a few hours, he was delirious. So keeping the person connected to what is significant for that person is also important, which can be faith, which can be religion, which can be the last communion that the person wants.
So we talked about physical, psychological, social, and spiritual. All
Yes.
these 4 aspects are equally important.
Yes.
First of all, I have read your book, Walk with the Weary, which I thought was a very powerful book. In that, I learned a lot about palliative care, the different layers of palliative care from that. See, one of the aspects that you highlighted in that book is palliative care is not really about just the doctor and the nurse, and it's not about treating a disease, right? It's a lot more than that. And there's a far larger audience which needs to be aware of palliative care and be part of it. So can you explain that a little bit?
Thank you. Very important thing. Thank you for giving me an opportunity to explain that. First, of course, palliative care is for all health-related suffering. It is not only for doctors and nurses, but all healthcare professionals, including the ASHA worker, the physiotherapist, everybody. But it is not only for the healthcare professionals alone. It's for every human being. Because when you are listening to this, you would realize that you have been a patient at some point of time. You have been a caregiver at some point of time. And if you have someone in your family going through a prolonged illness, you would realize also that the bulk of the caregiving is done by the family or the neighbors and not by the professionals. They are giving their input initially, maybe during a period of hospitalization. But including giving the medicines, everything else, including the physiotherapy, is being done by the family. And those of you who have gone through a serious illness, or why a serious illness, even a severe pain, including a back pain, would realize how your loved ones have sometimes been not too sensitive. You are in agony, and somebody says something like, "Hey, grow up, be a man." You are acting like a baby. And at that point of time, when your brain is at its vulnerable worst, that can be very traumatic. And even with something as simple as common as a renal colic, a pain arising from the kidney from a stone, one of my colleagues told me that if her husband had not stopped her, she would have jumped out of the 6th floor window. Pain is a personal experience and it can be beyond your imagination. So, caregiving is by the family, by the community, and the more the community becomes aware, there will be such a dramatic reduction in the burden of health-related suffering in the country. And in Kerala, the community participation, tens of thousands of volunteers have already demonstrated that, though we have a long, long way to travel yet.
Wonderful, sir. I think that sort of demystifies this entire thing for me. That was an insightful and inspiring session. With less than 4% of those in need receiving palliative care, we still have a long, long way to go. Palliative care needs to be integrated into the treatment at every stage. One of the key takeaways from what Dr. Rajagopal said is that every medical professional, while treating a patient, needs to remember they're treating a human being with physical, psychological, social and spiritual needs and try and alleviate all kinds of suffering instead of just treating the disease. Hope this happens across the country. This is the health worker.